with the glide scope and were done. The notes were that this was taken with some with precaution of having it doubly set up to do a crike, but that's probably, it was able to be done with the glide scope under good ED conditions, light, etc., and that probably was a good choice not to mess around in the field. He was taken to the CT where he had maxilla and nasal fractures, so his face was kind of done in, a small intraparenchymal right frontal lobe, and subtle poor gray-white differentiation, which means closed head injury. No skull fracture. C-spine's intact, TL spine was okay, but he had one L-spine transverse process fracture. Went to the OR for operative reduction of and internal fixation of the facial fractures. He had lip and eyelid lacerations as well that were done in surgery. He recovered in ICU, discharged home about 7 or 8 days later with cognitive defects. So he's got closed head injuries, not as sharp as he used to be. Family wanted to provide rehab rather than admit to post-hospital rehab unit. So patient is going to be followed by trauma clinic. I haven't seen the results of that since, but because of, it was a good choice. It was potentially difficult due to facial fractures and bleeding. So intubation might have been difficult, and the surgical crike was considered. Now this last case, which is sort of how we go down the garden path of assumptions. Patient 1 on, quote, unconscious fainting. On arrival on scene, find patient care of CCFNR, CCFD3. CPR is in progress. That's fairly impressive fainting. It was initiated prior to EMS arrival. Here's what the bystander said. They called 911. They're down the way, down the road from the patient. They see the patient riding a bicycle, and he falls off the bicycle. They rush up to him, or however long it took to get there, and they found him to be unconscious, unresponsive, and no pulse. So they began CPR. Fire arrives, they take over compression, place patient on monitor in AED mode, and it said, don't shock. Monitor is then moved to the manual mode, and the medic on scene shocked for what he said was ventricular fibrillation. Looking at the chart after the strip after the fact, this was probably simple asystole. So they continued. So they did one shock. Whether it was appropriate or not, it's another question. EKG. So then they did another look, and they determined this was PEA on the second after the first shock, after 2 minutes of CPR. Blood glucose is okay. IVs are started. Capnography. Patient's capnography shows CO2 value of 27. Medication is given epinephrine, altogether 5 doses of epinephrine given, because as we go along, the patient is intubated, CO2 confirms intubated. Oh, excuse me. No, did not make it. Did not. First one is a miss. And they notice food coming out of the tube. That seems to be an obvious not intubated patient then. So that was pulled, and they ultimately did another one. This time, they've got digital, they got an ETCO2 confirmation. Naloxone is given. Sinus tachycardia, they have an ROSC. They move the patient to the ambulance. Patient loses pulses, unable to get some more epinephrine, continues CPR, loses pulses again, gets more epinephrine, on and on and on. Keeps going. Altogether, 5 or 6 of epinephrine, gets to the hospital with CO2 of 55. Oh, no, it's not even to the hospital yet. CO2 is 55. It keeps going up. More epinephrine, CO2 value now 26. CPR goes on. GCS, of course, is 3. Pulse 31. So, what do you think about this case, just out of curiosity? I mean, have we made appropriate assumptions? The guy was riding along, they see him fall off, and they find him in cardiac arrest, that this is they're assuming he had a cardiac arrest and fell off the bicycle. Okay. So, on arrival, they also found this guy to be massively obese, massively swollen abdomen on arrival. Don't like that. Placed an E-wall lavage tube to decompress the stomach. Copious food and semi-solid food in the stomach. He was sent to CT for a trauma scan due to the mechanism. Because what if this guy fell off his bike and then had trauma? And it wasn't that he didn't have a cardiac arrest and fall off. Trauma scan was significant for frontal parenchymal bleed and a subdural bleed, so he had head injury bleed. His C-spine was he had multiple rib fractures on the right side in both the anterior and lateral posterior rib cage with a hemopneumothorax, unstable right chest wall, moderate amount of blood in, but no significant tension pneumothorax. Patient was still unstable, arrested again. They ultimately called the case. I think Marty took care of this case too. In retrospect, traumatic injuries were the likely cause of ultimate instability and arrest. The ME, he went to post. The ME found no signs of acute PE or MI. Did comment on the above trauma findings as well as a liver laceration probably due to a broken rib. Now, we're not faulting anybody. We're just saying we're going to have to consider trauma at the same time as cardiac arrest. Not that it would necessarily change your approach, except that blunt trauma arrests from blunt trauma are typically lethal. When you go to a blunt trauma scene and you find a patient in a car wreck, blunt trauma, patient's in arrest, you basically can call it. That patient's dead. So, it's actually pretty heroic events, but the ED, not that, I'm not sure EMS could have done anything differently or should have done anything differently at the time. It's just that this guy probably wasn't dead when he fell off the bike. He was probably dead because he fell off the bike. Older, obese people falling off bike seem to have chest injuries. Older people falling off bikes have chest injuries, as I know. So, at any rate.
He was not that old, let's say.
Well, it's 62.
62.
Yeah, well, that's.
But he was not in good shape.
Yeah.
His abdomen was impressive. It looked like he was pregnant, wasn't breathing very well.
Yeah. Remember the PC, and that's a really good
Yeah.
yeah, that's a really good thing about
The airway was not easy. I had
No.
had a limited view even with the glide scope, so it was a very challenging. I can understand why it'd be very difficult for people. So the decision to go to a super glide.
yeah.
Yeah, and the stealth trauma is a good thing to think about in your differential when you're in the PEA scenario, and you can't think of anything else that would be appreciated.
Well, the other take home is, even though it wouldn't have probably decompressed him with that, is that arrests that are not going well, or continued hypotension, continued difficulty to ventilate people, you have to consider things like tension pneumothorax or gastric distension. And often with, when we have people in, when you intubate somebody and you can then slide an oral gastric tube down, that might have, now in this case, they had to put in an Ewald tube, which is, garden hose size, to get stuff out.
Apparently, they eat recently.
Yeah. And frequently, and frequently. And then went for a bike ride to work it out.
Was he a DUI bike rider, or was he trying to get fit bike rider? Running around on trying to photos.
Yeah, great.
As a business owner,
So,
but yeah, even after we put in a chest tube for decompressants, I mean, there were
okay.
part of it.
Here's a couple quickies again, just to remind you that we have the SUDS program going on. That's mostly for the AMR people to think about. Fire can certainly remind them, but SUDS, sudden unexpected death syndrome. Any patient with a pre-hospital cardiac arrest, even and especially if you get an ROSC from, just get a blood sample from. The only thing we don't use in this, of course, just like everything else, traumatic, violent deaths, overdose. So draw a blood sample as quickly as possible. The kits are in the AMR crews, and label the tube, patient's name, EMS number, date of service. If you got a hospital face sheet, fine, good. Put everything in the baggie, put it in the ambulance cooler, move it to the refrigerator, and the soup takes care of it. Now, ALPS, we are still in ALPS. Non-traumatic out-of-hospital cardiac arrests, vascular access, IV or IO, persistent, recurrent VFib, VTAC after one or more shocks without open-label amiodarone. What counts as a shock? Any shock except for ICD shocks. Any AED device, any agency device, any ALS or BLS administered shock counts as the first shock. Study drugs have to be given as soon as possible. You guys are doing a great job. Haven't seen one missed. Actually, we've had a couple of Kongs, kit opened and not given because they've come out of the box and the patient had ROSC. And they had ROSC before you could get the drug in them. So, but that's the way it's supposed to be. That one we like. We don't like it after you've given 5 shocks and then you say, oh God, I should have given the medication, the ALPS drugs. VFib, pulses VTAC is treated the same way no matter when it occurs. So if you get there, you give a shock or two and the patient has ROSC, and then on the way in on the ambulance, they go back to VFib. That buys you a quick dose of ALPS drugs 1 and 2, along with another defibrillation. So the doses, the first 2 syringes are ALPS dose 1A and 1B. That's the first dose. The second dose, if they continue in VFib and require more shocks, is syringe number 2. Got to use that silly ClearLink adapter. I know you're going to miss that when it's gone. You put it on the tubing before you attach the syringe. That's how it works best. After enrollment, call the number. It's on the box. Call the number and tell them you enrolled the patient. Let the receiving hospital know that this was an ALPS patient. Now, in that first case we talked about today, they had ALPS 1 and 2, but they started the patient on the dose of, even though they know the patient got ALPS drug, they don't know whether they got amiodarone 1 or 2. They don't know whether they got amiodarone in that or lidocaine or normal saline, but it was no problem for them because they could start an amiodarone drip without any issues. Now, ALPS is almost to a close. We're beginning to put things together, and we're doing very well in our area. Clark County is still the furthest ahead. We still have the most ALPS cases. And it's anticipated, we're anticipating that we'll have enough cases in and they will stop the study by the 1st of November. Now, don't worry about that because we'll let you know when they stop the study, we'll notify the agencies that all of the ALPS drugs will be returned to ROC. At that time, we will go back to our original orders, which is instead of using, when you need to use an antidysrhythmic drug, you will then have amiodarone available. That's the drug we'll use until we get the results of the study. The study is, I don't think we'll actually get a final answer until probably March of next year, if I know how these things work. Probably somebody at Rock Central will have the answer by Christmas, but if they tell us, they'll have to kill us because you can't let this stuff out. The rules of this game is silly. Even if you know it works or something works the right way, you can't let it out until it's published for everybody. So we will go back to amiodarone like we used to have. But we'll let you know that, and we'll make sure that the agencies have the drug to put on into your kit. But the rock things will just disappear when we say it's going to disappear. Any questions? You guys are doing a great, I mean, really, we haven't had a miss that I can think of over the last several months where the patient, where you didn't anticipate that the rock med should be given, that the ALPS drug should be given. And then the patients have been just not cooperative. They're having RSC before we can give it to them. So that's okay. All right. Next month because we haven't figured out entirely next month, have we? Okay. All right. Thank you. Yeah.